Hello and welcome to HealthTech Hour on UK Health Radio, the UK's largest talk health radio station. My name is Steve Roest, and each week we bring you the best news, views and interviews with the leaders, clinicians, CEOs and founders who are changing the face of healthcare in the UK and beyond. I am the CEO and founder of a health tech company myself called PocDoc, and I'm passionate about the people and companies that are changing the world. Thanks to everyone for listening to the show, whether you're listening live on UK Health Radio or whether you're listening on one of the podcast platforms, so syndicated out through Spotify, Apple, Amazon or Google. Welcome to the show. Thank you very much for listening. We wouldn't be here without you. Please follow the show on the socials. It's at HealthTech Hour. Please also follow the station, which is at UK Health Radio. There's a ton of presenters on the station doing some really great shows, so please follow just to make sure you stay on top of everything that's coming up. After last week's show was with Kate Bratt-Farrar, the CEO of Heart Research UK. Check it out on your podcast platform of choice if you missed it. It was super inspiring to hear her journey and why she does what she does, what her so what is, what gets her out of bed, and why she and how she can stay on the mission of effectively keeping families together and stopping people dying. We're actually returning to the area today of individuals and companies who are helping the NHS save millions of pounds a year through better care delivery and helping people who suffer from long-term conditions live healthier lives by using technology. Now, there's a lot in there that we're going to unpack through the show, but on today's show, we have the CEO of Spirit Health Group, Chris Barker. Chris has had a long career supporting the NHS in the UK and has been CEO of Spirit Health for over 10 years. Now, Spirit Health is one of the fastest growing service providers to the NHS in the UK, and their services touch millions of people across the UK every year, covering everything from GP surgeries through to the home monitoring of diabetes and COPD. Chris also describes himself as Chief Mischievist. I think I'm not sure whether I said that right, Chief Mischievist of Spirit Health. And that bodes for a fun show. So Chris, welcome to the show. How are you?
I was okay until you described my really long career in health, Steve, and I thought,
I mean,
I'm really old.
It's a compliment. It's a compliment.
Thank you. Yeah, delighted to be here, Steve. Thank you very much.
Good.
I have a hard act to follow after last week's podcast.
Yeah, it was good. It was really good to get Kate on, and it was kind of the end. We did a February is Healthy Heart Month, which you may or may not have been aware of, but we had a kind of a series of people. So it was really inspiring. It's always very good to get on the show. We like to have a blend of people that work in private companies and people that work in not-for-profit, and actually consistently across all of them. And I'm sure that we'll get into that with you. Is around there's generally a personal mission or a personal drive as to why that they do what they do. And I actually think within not-for-profit, that's even stronger, as a calling. So yeah, it was a good show. So as everyone listening probably knows, or regular listeners will know, we do the show in 3 parts. So the first one is really more of an origins around how you came to be doing everything that you're doing. The middle bit is all of the amazing stuff that you and Spirit Health are doing. And then the final bit is more around, motivational. Generally, how do you stay on your mission? How do you keep going? In what is, well, it's been a pretty tough couple of years, but also healthcare in general, is a tough industry. So let's kick it off. When and why did you decide on a scientific healthcare career? Because I think that you ended up choosing, from what I can tell, a sort of relatively scientific degree at university. Did you not? So how was that journey for you?
Yeah, so I started off, I guess I came from a medical family. So right. my father's a doctor. And whilst it was never impressed upon me that I had to enter that field, yeah, my persuasion was always a little bit towards the scientific and the academic. Mm-hmm. And being brutally honest, I was just terrible at the arty stuff. Okay. And I think I certainly enjoy playing to my strengths. So for me, I took a degree in pharmacology. I'm not sure it was my favorite time, and I was really keen to get out into work and apply that in a way that was then useful.
So pharmacology is one of those words that many people listening may have heard without actually necessarily knowing exactly what it is. How would you define pharmacology?
Oh, Steve, you're hanging me out to dry, really.
You did it for 3 years. Come on.
I did it I did as little as possible of it for 3 years. Probably the honest answer. So pharmacology is the study of drugs and their mechanisms of action, how they work, and how they impact the body.
Okay.
Whilst I'm being a little bit facetious, actually, it's really important in the field of medicine and how those drugs then have a positive or indeed negative impact upon the body. Fairly topical during the time of vaccines and COVID and all the things.
I imagine. And so was that like, what of all of the different sort of medical, quasi-scientific sort of degrees, why that one versus many others that would have also fitted in with that sort of definition?
Because I was a really arrogant 17-year-old who thought that I'd walk my A-levels because I was quite smart, but actually, relative to what I could have achieved, I didn't do as well as I would have hoped. So it was a degree that I could get onto and that helped me move in the right direction without having messed up too much.
Nice.
The honest answer.
We like honesty.
And it was essentially it was a step up into a career really in sales and marketing. So whilst in my degrees in science, actually, if I look at my core strengths, probably sales, marketing, and building teams are more where I see myself having success. I'm surrounded these days by far better scientists and medics than me.
Yeah, I know that. Pre-show production call, I know that one of the big strengths of Spirit Health Group is the team and the emphasis that you place on culture. So we can come into that as we move through. So from the pharmacology sort of degree, did you have a sort of journey mapped out intentionally that sort of led you to where you are? Because I think you sort of continued on within the healthcare field. Did you sort of not straight afterwards?
So I was really lucky to go and have a career working in big pharmaceutical companies. So I went to go and work for Johnson & Johnson, one of the biggest healthcare companies in the world, and I benefited for the best part of 7 years. I think it was of their training, of their upskilling, of the passion and enthusiasm that they also have for changing the world. And I think probably that helped shape the foundations really of my thinking around value sets and how we look to create what we do going forwards.
How people talk about the value of the value that big pharma invest in their people, invest in their training and development. It sounds like that's true. Those stories are true. There's a pathway and it's clear and there's a proactive development. And, it seems like that's what you were sort of saying there.
My experience, 100%. I absolutely owe a debt of gratitude to the teams that I work with at J&J. I personally was invested in very heavily, both with time from managers, but also structured training and leadership courses, formal programs. And yes, at the time, accepting it was the best part of 20 years ago now, Steve. Certainly for me, it was a really rewarding time, and probably one that, except for personal circumstances, wouldn't have ended.
Right. And so at the time when you were there, what was at the time, outside of like drug development, obviously, outside of that, what were the type of technologies, and what was digital healthcare a thing at that point, or what was around, and what were you interacting with? Like what did tech mean at that point? For your peer group and the people that were around at that time.
Again, I'm going to sound really old, but I think the tech that was around at the time was probably a Nokia 3210, Steve, which felt like the height of all innovation. Because we could text message. So in reality, 20 years ago, it was really primitive. We were starting to use data analytics and starting to use what at the time we thought were really advanced techniques. But in reality, now looking back, it was just the beginning. They starting to, from a sales and marketing perspective, e-detailing wasn't a thing. It was just being thought about. Some of the drug discovery work was starting to be automated, but in the really early stages. So it was a very forward-thinking company, but it feels like in a different generation when you look back.
Yeah, I mean, a heck of a lot's happened, not just in the last 20 years, but last 2 years, which we can sort of get into. So how did you sort of transition from that pharma into, because you've been at Spirit Health now for, over 10 years. And so how was that transition? And also, what was Spirit Health like when you joined it, 10 years ago? Because I suspect it may be the same. I don't know. It may have the same mission, but I imagine a spread across a much wider variety of services. But you tell me.
Yeah, so I left Big Pharma to found Spirit back in 2009, and yeah, the objective really was to start building something that I felt didn't exist. For all the good things about big pharmaceutical companies, one of the challenges that they have is that they have a large base of shareholders. They have a challenge around how they structure themselves, and they're not necessarily quick to react to changes in the market.
Right.
So for me, there was an opportunity with Spirit to go make a real difference. And at the time, and I guess what was different initially was that our focus was largely on the UK. Yeah, and our focus was largely on clinical service provision in the UK, and the provision of pharmaceuticals and medical devices into the National Health Service. Our objective was still the same, really, which was to cost effectively improve care for people and give better access to medicines.
And so when you were a big pharma, and then at what point did you think, do you know what, I'm going to go and start my own company? Because a lot of people stay in big pharma because it's a fantastic pathway and there's training development. Economically, one is compensated very well. There's opportunities to travel, so on and so forth. But it's a big change, right? To go off and found your own company. So, were you mission driven, or was it serendipitous, or what? How did that sort of play out?
Like most things in a Spirit world these days, there was quite a large chunk of serendipity involved.
Right.
So I left Big Pharma to go and do consultancy work. So I felt that I could have a bigger impact on the work I was doing by working in consultancy directly with health services.
Right. When you say health service, you mean like the NHS,
correct.
Primary, yes. Yeah. What do you? Yeah.
Yeah. So I was again going back several NHS reorganisations ago. I was working in primary care trusts and in the separation between provider and commissioning organisations. And I guess I'd always had this. Yeah, my mission in pharma over time became to help the NHS restructure and reorganise itself so that it could be effective in that service delivery component. But I always felt a little bit like an outsider because ultimately you were working for another organisation, so there absolutely was always two agendas operating at the same time. The two agendas were very much congruent. You could work on them together, but I always felt like a slight outsider. So I wanted to go and do the consultancy work because I felt like, well, if I'm part of it, I can make a bigger difference quicker and faster.
Yeah.
I was ultimately wrong. As happens repeatedly throughout this story, Steve. And what I found was that actually it was just as challenging to change the system from within it. And therefore, absolutely utmost respect to anybody that is able to do that currently and beyond. And I hope that from those lots of mistakes, we're starting to make a bigger impact these days than we did at the time.
And do you think going back, because as you said, there's been reorg after reorg after reorg, but going back to that time when you were trying to sort of help or play your role in those restructures, was it clear do you think the goals were right, executed wrongly, or was it just a process and one thing led to another and that's fine, but it's just such a big organization with so many issues that it just takes a heck of a lot of time to get it right?
So I think what the NHS is trying to achieve is brilliant, and I wish that every single person on the planet had access to a health system like ours, not just in the UK. Having said that, it has its challenges. What are its challenges? It's massive. And it's got lots of different moving parts, and those different moving parts are both complex and not always well interlinked. And that's true both between different counties or parts of the country in the UK, but it's also true within those same areas when you start looking at the mix of health and social care. So for me, it's the difficulty of bringing all those stakeholders on the same journey. There's also a challenge that, particularly in the health service, people go into the health service and work in it for life. And so what you see in private industry, where people move around different organizations and get a different flavor for how things work, doesn't necessarily happen, at least not as much in the NHS.
Right.
So actually persuading people who've done something one way for the last 20 years to do it differently, it is really tough.
Well, also when there's there's no risk in sticking with what you know, right?
Correct.
And when you're dealing with health services, then and there's a potential patient issue at the end of the chain, then risk takes on a very different sort of complexion, right? And introducing more risk into the system. Yeah,
completely. And actually, and I don't want to talk about COVID too much during the next hour because you could fill it with the whole hour, but arguably, when you look at digital health and COVID, that's exactly what happened, was that the risk shifted to, it was less risky to do a different model.
Yes.
So completely, medicine is about reducing and minimizing risk to patients all the time. The Hippocratic Oath, first do no harm. So actually change, whilst I can be I can try and describe it as a simple thing, it's really not when it's being ingrained into do the least dangerous thing first.
It's really, it's really difficult, and you can completely appreciate why, if something has worked okay for a long time, then why would that change? Now, obviously, like you said, the last couple of years has kind of blown a lot of that out of the water, through some necessity. So you started Spirit with the aim of improving the cost effectiveness and availability and speed of delivery of just medical supplies and drugs, pharmaceutical supplies. And so how did that, I guess it went well because you sort of evolved, but what was the evolution? Because obviously from what I can tell now and what we talked about before, Spirit Group itself is now a very mission-driven organization with lots of different services. So I'm just interested on how that journey sort of started to happen, really.
So where did we get to? So we started off with those prescription products. So products that can be prescribed. And then what we tried to do was add value to the patient journey along the way. So we weren't satisfied with just having the products that delivered the end result that was initially needed. So we started creating clinical services that supported the use of that product, and then eventually digital interventions that supported the use of supported patients who use those products as well. So if I look at it now, you've got, yes, absolutely, that medicines optimization service. So that's service that reduces the cost of medicines whilst improving the quality. You've then got the primary care services, but then off the back of developing a small amount of digital support, we now have a digital health platform, and our mission very much has become, how can we make healthcare accessible, affordable to everyone, not just in the UK, but around the world. And that's the real driver for how we go and make that happen.
Yes, and we're going to get into that in the next part of the show. So we're going to take a couple of minutes now for a commercial break, and you've timed that very well in terms of where you stopped talking there. It's very good. It's almost like you've done this before. So we'll be back in a couple of minutes, and we will get into everything that Spirit Health is doing right now. And particularly, I'd like to, I think with organizations like yours, because you do so much, and you do so much. I mean, there's so many interventions, so many services, and so much value that you're delivering across the health system. I think it would be useful for everyone just that if we flipped it around slightly and first of all dealt with what are the problems that you solve, and then we can do the how, because the how is actually, obviously with any complex system, delivery of it is actually relatively complex, but the problems you solve, I think, are universal or almost universal for everyone listening. So, I think we can start there if that's okay with you.
I will do my best.
Good. Okay. Well, look, we'll be back in a couple of minutes.
Thanks, dude.
Vitamin C supplements. Usually only a small proportion of vitamin C actually reaches your cells and has a positive effect. Whereas the high absorption levels of Goldman Laboratories liposomal vitamin C help maintain optimal vitamin C levels in your body and strengthen your immune system. Now get 10% off when you choose Goldman Laboratories liposomal vitamin C capsules. Just quote 10 off at goldmanlaboratories.com. Do you suffer from pain? Meet your laser, a new CE approved medical device for the effective treatment of pain, is now available in the UK. The results of a double-blind trial has shown that B-Cure laser offers a significant reduction in pain compared to the placebo group. To get your special B-Cure offer now, call free on 0808 501 5122 or Google Radio Pro London. B-Cure laser. B-Cure laser. UK Health Radio, the station that makes you feel good.
Hello, and welcome back to this week's Health Tech Hour with me, Steve Roest, your host, and Chris Barker, the CEO of Spirit Health Group, which is one of the leading service providers to the NHS in the UK. So before the break, we were just trying to understand, or Chris took us through his journey to founding Spirit Health and why he did that. I think now what I'd like to do, as I said before the break, is I'd like to, if possible, Chris, if you could just, and you can do this sequentially, because I know that your business grew over time, but what are the problems and how did you come across those problems that Spirit Group decided to go and solve? Because obviously within the healthcare system, there's a lot of problems out there that you could solve. So how did that evolve?
Yes. So I guess when we first started, it was about looking at inefficiencies. So it was about looking at the fact that, because it's a big system, there are lots of relatively small inefficiencies to anyone looking at the entirety of the system. But once you start adding those together, they become quite big. So we started the business really looking at how we could provide the exact same products and services that somebody else might be providing, but do them in a different way.
What were some of those efficiencies, or one of those efficiencies, just off the top of your head, just as an example?
Oh, so a really simple example is that we were able to launch medical devices that were exactly the same quality as ones that are already on the market, but discount those by 20 or 30 or 40% from the standard pricing.
Okay.
And the way we're able to do that was that we didn't have the large sales and marketing expenditure that some of the other organizations in the market might have had.
Right.
And we dealt with budget holders rather than talking to lots of individual prescribers. So we're able to streamline our operations and how we worked so that the value was passed into the health system rather than spent on increased sales and marketing costs.
Right, because potentially, let's say if you're a medical device developer, or even there's the developer, the person that manufactures the device, that's then distributed through somebody who then may sub-distribute, and each of those people add on a margin. And any of those people can then try and get a contract with the healthcare service. And depending upon how far down that chain the healthcare services choose to contract, that will then dictate how marked up that price is. Is that sort of roughly how that played out, or have I simplified it slightly?
I know I'm supposed to agree, but I'm not going to.
No, you don't have to agree. If I'm wrong, I'm wrong.
So I've articulated, I think that's true in certain circumstances, but I guess the markets that we work in, so take diabetes, for example, actually the pharma companies will mostly operate in those markets themselves, as will the medtech companies. The challenge for those companies is going back when Spirit first launched 10 years ago, 12 years ago, it was those companies marketed themselves through hundreds and hundreds of sales reps. Hundreds of medical representatives and several layers above that into the market. And what we were able to do was quickly adapt and change that model.
Right.
And those large multinational companies are a bit like oil tankers. Of course, they change and they flex, but it takes them much longer.
Right.
So what we were doing 10 years ago, they are now absolutely doing, but they weren't then. To them, that time, it was something that was new and different, and we were able to lead that charge.
That's amazing. And so you started with the inefficiencies, and then how did it evolve from there?
Yeah. So what we then discovered was that actually, whilst there's inefficiencies on prescribing, that's almost a zero-sum game in the sense that it becomes a little bit of a commoditizing game where absolutely there's value in doing it because it still gets best value for the healthcare system, but other companies into the market started looking at what we were doing and creating similar types of projects. So what we then looked at was how can we add the same type of efficiencies, the same type of systems and processes, but into the clinical service delivery. So into how services are delivered so that you can make them both better and more affordable. And with that, comes technology. With that comes appropriate use of technology to try and find different touch points for patients within systems, and to take the health service from being something that currently is quite reactive. I think I'm on record as saying that the National Health Service should be called the National Illness Service currently. And actually, let's try and make it a health service that we focus on proactive healthcare and keeping people well and healthy, rather than just treating them once they become poorly.
Yeah, I like the difference between, preventative, proactive care to someone just saying, oh, I'm sick, I'm going to go and see the GP.
Yeah, correct. Yeah, and we run primary care services, and the best way for us to manage our demand as a primary care service, as a GP practice, is to make sure that our patients are well and don't need to come to us.
Right.
And that's not because we don't want to see them. That's because the best care for them is the care that means they haven't got to come and see us in that way. Or that we're contacting them so that they come in before they know they're poorly, and we can treat something quicker and faster.
Yeah.
And that's been our driver, realistically now for the past 7 or 8 years.
And at what point did this sort of, what we now, I'd say, not euphemistically, but people talk about digital healthcare. At what point did what we now know as digital healthcare start to come into what you were doing? It might have been there from the beginning, but when did that happen? And was it like a light bulb moment, or did it just sort of creep in?
So like most things that are great about Spirit these days, it was very little to do with me. A colleague of mine suggested that he'd seen some technology in the US that he thought, on one hand, worked brilliantly, and it was a very old till that a company used to go and place into a patient's house with USB devices plugged into the back of it that enabled them to monitor people's health across the country in the States. It was a Windows 95 till. So by today's standards, very, very old technology.
Yeah.
But for us, in 2011, that was the start of our journey.
Wow. Something in 2011 running Windows 95 as its operating system. Wow. Yep. That's amazing. That is really amazing.
Yeah. So we then spent some time looking at that and working with it, and in the end ended up building our own version of it.
Cool.
I hasten to add, not in Windows 95.
No, Windows 97, right? You upgraded, got the new version. Good. Okay. And so, let's talk about all of the things that you do at Spirit today, and sort of how it's going. So I know that when we caught up before the show with the show planning call that we always do, there's a lot that you guys are doing at a really high level. So I'll kind of open the floor to you to sort of explain a bit about that with, however you want to do it. So, but yeah, because you are doing a heck of a lot.
I don't think we are. I think we should be doing more. But
you can still do a heck of a lot and still find more. I mean, there's no maximum cap here.
Yeah, so I'll probably describe 2 parts of what we do fairly briefly, not because they're not important, but it's a health tech podcast, so I'll focus more on what we do in the health tech space. But so what do we do currently? So we still provide those medicines optimization services. So we still work across the health service in the UK, and that part of the business is growing really strongly. In there are teams of pharmacists and nurses that work with the health services and make a real impact on both the quality of care and also the effectiveness of it. We then also run both primary care services and kind of intermediate out of hospital services, so that space in between GP and hospitals. And that's a really good place for us to actually feel what it's like to work in the health service.
That's the front line, right?
Oh, 100%. We've got teams of GPs, doctors, nurses working their hearts out in those surgeries, and the relevant managerial support to do that as well. And I must give them a shout out for the work they've been through in the past couple of years.
I mean, I was going to say the last couple of years must have been just, I can't even find the words.
Ditto. And the resilience they have had to take on more and more and more at a time when they're already, I can't swear.
No, that's the one rule about the show. Johan will kill you.
I'm hoping that, I think of another word other than that, but they're absolutely exhausted is a word that I think I'm safe to say. And yet they still push on and push through. And for that, I am eternally grateful to them, as are our populations of patients. The last bit that we do is our digital health platform. And once again, we started out with a mistake. We took that platform that we saw in the US, licensed it for a while, then built our own version of it. And we built it in a really rigid way originally, in a way that worked brilliantly. We have published data in peer-reviewed journals that says that original pathway that we built reduced unplanned admissions in COPD patients by 2/3, by 67%. We could increase the caseloads that clinicians could manage, and patients got statistically significant improvements in care.
Mm-hmm.
The problem was that we built it thinking with a tech head and thinking with the head of how we can make the best pathway. We didn't build it from our hearts, really, knowing that what the health service wants is something that's localized and a little bit different in different parts of the NHS, but also in different parts of the world.
Yeah.
So what we've done now is taken the methodology that we used to build those first pathways that got those tremendous results and built a platform that allows any local clinical team to digitize their pathway. They can start from scratch, they can adopt someone else's, but ultimately we can make that experience digital and indeed, and this is probably the key bit for me, proactive. So
let's break that down a little bit, just so all of the listeners are on the same page. When you talk about a pathway, you mean you effectively that's a sort of formal term, is it not, for just how somebody is someone has a disease or is presenting with symptoms of a disease, how they proceed through the health service? Is that what that means, or how would you define pathway?
Yeah, I think on this occasion that's a brilliant way of describing it, Steve.
Oh, right, I got it right this time. That's good.
So a pathway is it could be the entirety of someone's journey from diagnosis right through to death, or it could be a small part of it. I guess there are different interpretations by different people on the exact definition of what a pathway means in this context. To us, the definition doesn't really matter, actually. What we do is enable either a small part of that experience or the whole extent of it, from diagnosis to the end, to be digitized.
And I think that we'll come on to, because you were doing this before COVID just completely blew the doors off the digital health space. We'll come on to what's happened as a result of COVID, but you were doing this before. And you originally focused on COPD, which is chronic obstructive pulmonary disorder, I believe. Is that correct?
Chronic obstructive pulmonary disease.
And so could you just give us a quick 30 seconds on that disease and why you focused on it and why that's such a big problem for healthcare services, not just in the NHS, but other parts of the world?
So COPD is a disease that causes essentially a stiffening of the airways, and it's a constant decline. So it is not something that you get better from. But with each decline, it's not a steady linear decline. It's like walking down steps, and with each step, your quality of life and your physical health deteriorates quite rapidly. So what you can do in COPD is try and avoid the steps. Because then someone's quality of life and indeed physical health stays better. And
just to be super basic about it, if someone's quality of life is better and their general health is better, not only is that better for them and their family and whoever is looking after them, it's also better for the healthcare service.
Absolutely, yes. So if someone has something called an exacerbation, which means one of those, you're walking off one of those steps and you're getting periodically worse, then you typically will end up in hospital.
Right.
If you don't react to it really quickly, really early, end up in hospital. And a severe respiratory patient going into hospital is both horrendously expensive for the healthcare system, over £4,000 a time in the NHS, but also really bad for that patient because their quality of life doesn't go back up to where it was. So we focused on that because we felt that we could work with patients at home who are already supported by clinical teams, so specialist teams, and we could help to spot things going wrong quicker and faster than you would during normal non-digital care.
And the reason for that is that by spotting them faster, quicker, more effectively, it allows for quicker treatment, them to be addressed, which then leads to better health outcomes.
Yeah, correct. And I can probably speak the words of one of our patients from those really early days, who described it. It's like having my nurse come to check up on me every day, or whenever I fill my results into the system. So how she used to describe it was that it was, when you've got a normal chronic disease nurse management system, when the nurse comes to see you, she checks how you are. If she comes on the right day, that's great. If it's not the right day, as in when an exacerbation is about to happen, then it's a bit pot luck as to whether he or she picks up the challenge. So what we do is we enable that clinician to see that patient and their state all the time, or as frequently as the patient fills out the details, and trend it. So you get to start to see trend analysis, all the things that we start to look at in digital tech, and see it more proactively.
Because you were doing this before people would, so this is what generally people refer to as sort of remote monitoring, remote patient monitoring. But you were doing this before people were talking about it as that.
Absolutely.
I think, right. Yeah. You were just doing it because you felt like it was a natural extension of why wouldn't you do this? It's using technology to just deliver a better version of the care that's already being delivered. Is that sort of fair?
That is one of the best definitions I've ever heard.
Oh, look, I'm getting better at this. So do you, that patient aside was one particular instance, but was that reaction sort of consistent across the board when you first started doing this? Or was there a pushback either from the clinicians or from the patients? Because it's sort of now 2022, it's like, oh my goodness, that is like completely logical, and like, of course we should do that. But I'm sure it wasn't as smooth as it wasn't all smooth sailing, I suspect.
Absolutely not. So feedback from patients was overwhelmingly positive. Feedback from patients, it wasn't for everyone. Let's not pretend that anything in healthcare is. No. But of the patients who wanted to do this, of which over 80% of patients would be really keen to get involved in this.
Wow, that's huge.
It's phenomenal. And the feedback from those patients, in patient satisfaction scores, is over 90%.
Wow, that's cool.
So patients who want to do it really like it. Clinicians find it a challenge. And we work with some amazing, brilliant clinicians who've really embraced this. But ultimately, you're asking clinicians to do something really differently to how they've worked. And I guess I'm going back to when we started here. We were asking them to do something completely alien. You mentioned risk earlier on. We're asking them to trust in some technology rather than them seeing patients themselves. That's really tough. That's almost like a conceptual issue for them. It was just a completely new concept, was it? And they just so I guess it's a new concept. I don't think the concept necessarily was the issue, because the concept's a fairly straightforward one. The difficulty was trust. The difficulty was, well, if I see a patient face to face and I make that decision, then it's on me. It's my accountability. And that's what someone's used to. We're saying, we were saying, trust that the results you're seeing on your computer in front of you are as reliable for you to make those same decisions. And that's why we felt that going and getting the evidence to support this and getting that published and peer reviewed was really important, because that enabled those clinical teams to have that trust.
And so on that note, we're going to take our final commercial break, but after that, we're going to dig into this concept of you proactively or actively pursuing publishing research papers in peer-reviewed journals, which, let's be honest, not every digital healthcare company does, and not every healthcare company does, to be quite honest. It's a much, much harder pathway. And I know that there's lots of good reasons why you did it, which you sort of just alluded to, but I want to get into that because I think it's really interesting and a real USP of what Spirit or how Spirit Group has been sort of gone about what they're trying to do. So we'll be back after a quick break.
Is the quantum energy emitted from the universe, from the sun and stars. Now, Unplanned, a humanitarian and scalar light researcher, has created the world's only scalar light healing system, a system that can bring long-distance healing and plants via a photograph. Get your free 15-day trial now at scalarlight.com. skill I like better on the UK Health Radio website. Shields like masks are top of mind right now, but did you know you have inner armor working constantly to protect you from pathogens? It keeps you healthy and thriving. It's your immune system. Ion Gut triggers the body's natural ability to support gut strength all year long, so your immune system can protect you when you need it the most. How are you treating you? Visit uk.ionbio.com to learn more. Ion Gut. Protect what protects you.
Information that makes you feel good.
Hello, and welcome back to the final part of this week's HealthTech Hour with me, Steve Roest, your host, and Chris Barker, the CEO of Spirit Health Group. Now, before the break, we were getting into the research component. So, why don't you take us through what exactly you've done, and more importantly, I think the why, because you didn't have to do this, right? You could have had a business that delivered the services that you deliver without investing in what is without doubt a fairly arduous path that you didn't necessarily have to tread, right? So walk us through it.
So yes and no, Steve. So I would argue that we probably did have to tread it. And perhaps that's in part down to the culture of the business, how we operate. So you mentioned at the top of the hour that I've got two job titles. One's chief exec and one's chief mischievist. And some of that comes through in how we work with people. And yeah, as a culture, we like to have fun, we like to be engaging, and we like to make it interesting to work with us. But I guess the downside to that is that we then also have to demonstrate that actually we're really good at doing what we say we're going to do as well. So yeah, for us in delivering healthcare, yeah, we want to know that what we're doing works and makes the impact that we think it will. And it's not good enough to have a gut feeling or an assumption that it will. So we employ teams of scientists and health economists who work with us to make sure that, yeah, not just in digital health actually, but across everything that we do, if we're going to do something, we measure it, and then we publish openly the results of what that does. And for me, Steve, that gives the balance between us wanting to have fun and enjoy the impact that we're making, whilst also demonstrating that we're really good at what we do at the same time.
Right. And was that something that you had in your minds from the beginning, or was there something that happened where you said, actually, one of the ways we can solve this challenge is by going down this pathway with research? Or was it something you were like, no, we're going to do this from the beginning because it's the right thing to do?
Again, like a lot of things, it came from feedback. It came from listening to people. So one of the challenges of deploying digital health, so clinicians in the early days, was that people said, yeah, how do I know it works? Where's the evidence that supports it works? Yeah, people felt quite intuitive that it would. But actually, yeah, clinical teams wanted to see some evidence.
Right.
So it was, in the very earliest days, it started off as coming from feedback. Now it's absolutely ingrained into what we do. Yeah, we don't set off on a project without working out what data we have to collect to make sure that we can evaluate it effectively at the end.
Right. And what does that data show? Like what have been the results of the various bits of research for your technologies?
Oh, God,
or services?
Yeah, there's that many. It starts to get so if I focus on the digital side, you know, I've mentioned already the 2/3 reductions in unplanned admissions to hospital,
which is huge. I mean, that's enormous.
Oh, it's phenomenal. Yeah,
that's enormous.
Yeah, I mean, if that had, I can't evidence this, but my suspicion is that if that had been a pharmaceutical product that had got those results, yeah, that would have been what's known as a blockbuster product across the world.
Yeah, and so that was with your COPD digital pathway.
Correct. Yes.
And that meant that there were 2/3 fewer unplanned admissions to hospital from the group of people that were using your digital pathway.
Yeah, correct. So that used a control group and compared people to the previous year as well.
Okay.
So that was essentially comparing people to themselves and also to other people who were in similar conditions.
And what do you attribute that drop to? What elements of the technology or of the service do you attribute that drop to? Or maybe it might not. Obviously, it's the whole thing, but I'm just sort of interested to see.
I think so. In that particular case, I think it's a really simple answer. The answer is that we were able to see someone exacerbating, so someone getting a bit worse, much quicker.
Right.
So typically, you can start to see an exacerbation in COPD over about 3 days.
Okay.
So if you remember, I said a little bit earlier that one of the challenges with the chronic disease management type model is that whenever that nurse is talking to you, it's look as whether it's the right time. And the look means that you have to be seeing the patient on one of those 3 days.
Yes.
Or the patient has to recognize the signs themselves and do something about it proactively. So what does ClinResearch do? What's the difference it makes? First of all, it enables people to see that change over time. The clinical teams can see that change and see someone going off or exacerbating quicker than they might have done.
Right.
The second is that you can teach patients so self-mastery at the same time, because they're also seeing it quite systematically. So
they can see it as well, right? It's both sides.
And then going back to the patient side of things again, you've got a patient who's been monitored for respiratory disease, for COPD in ClinResearch, and the first time that they start to have an exacerbation, the nurse will message them either through the system or by a phone call and say, you're having an exacerbation. It looks like you're starting to have an exacerbation. These are the signs that I'm seeing and reading. And each of the patients has something called an exacerbation pack.
Okay.
It's basically a steroid inhaler, which if they take that early enough, it prevents the exacerbation.
Does it really? Wow.
And obviously that's
so hold on. So the downside of an exacerbation is enormous, but the intervention is a simple steroid inhaler, but just has to be taken at the right time.
Correct. And
wow,
the latter part of that sentence is the hard bit.
Right, because you need to be able to connect what is a very simple device with the right time period to do it in, which is very hard without a digital platform to do that.
And sometimes it might be a combination of different things, not just the steroid inhaler.
Okay.
But ultimately, that exacerbation pack is something which is well documented, well researched, and it's about supporting and educating people to take that at the right time. So what our system ultimately did in that scenario was spot people for the right time to take their medications, and those are not our medications; they're someone else's, by the way, of which there's a number of different providers, and the second thing it did was the first time a patient sees the exacerbation happening, the first time they know about it is when the nurse contacts them. The second time when the nurse contacts them, they're kind of going, oh yeah, it's an exacerbation now, isn't it? I should take my medication. The next time, they've already taken it. So you're starting to, the patients and individuals with these conditions are starting to also build up a better... Well,
I mean, let's just be honest, like who in their right minds wants to go and be admitted to hospital?
Correct.
I mean, I'm sure there are some people, right? It's never 100, it's never 0%, but it's not a very high number, right? I mean, if you could do anything to stay out of hospital, you're going to be pretty incentivized and inclined to do that and get on top of it, I would suspect.
So I think in terms of staying out of hospital, yes, 100%, I agree with you entirely. I think there is a bit of a social aspect to some of the care that happens. One of the challenges that we have, both in the health system but also the social care system, is isolation. I think, I don't want to suggest that what we're doing is perfect. Arguably, we're delivering better healthcare, but taking away some of the social contact that some of these people have. So often. So I think we still have a long list of challenges to go and work on, such as how we reduce.
I mean, it's an interesting question, which is sort of that's an interesting. I mean, it's almost an ethical question, isn't it? Really, which is sort of a nurse is a healthcare professional in that instance. In theory, she's providing healthcare associated with a condition, but actually his or her visit has the ability to deliver healthcare services beyond that then verge into social care. But is that what should be happening, or it's just a nice upside? It's kind of it's a tricky area, isn't it?
I think it's really difficult, because on one hand you can say, well, there must be more efficient ways to deliver that social aspect of of the role. But actually, if someone's fulfilling both at the same time, does that make it
okay? Like what? Yeah, exactly. Like, is that okay?
Yeah.
And then, but if that's okay, then should that get then sort of put back into the evaluation of the value of that role and that service when people, do the health economics? Yeah, it's interesting. So let's.
And actually, we have measured socialization whilst using digital. Research. And overall, once you add everyone together, there is certainly no net negative. In fact, it's a slight net positive.
Oh yeah. Okay.
However, and that's because they feel like they're more in contact with the teams who are supporting them.
Right.
When you ask for specific words. Having said that, that's not absolute for everyone. That's an average. That's a normal distribution.
That makes sense. So let's talk about COVID, because we managed to kind of avoid the elephant in the room for a good chunk of the show. But obviously your services, particularly in the digital space, will have changed, expanded, accelerated over the last couple of years. So what has been that impact? I mean, and how, I don't know, what has been that impact on what you were doing? Because you were doing a lot of it before in this digital delivery, digital pathway space. And so what happened and what's happening now?
So I think the simple answer for me is that when it came to digital, COVID flicked a switch. And it flicked a switch not just systematically, but also in clinicians' minds, where the risk of seeing a patient face to face for the first time was perceived, right or wrongly, to outweigh the risk of delivering care digitally, because the risk of catching or transmitting COVID was perceived as too great. So care, pretty much overnight shifted towards remote delivery.
Yeah.
Now, remote delivery could be lots of different things. It could be the telephone, or it could be digital solutions like ours. What we saw was, in the first 2 weeks of COVID, when the first lockdown came, we deployed the same number of units that we expected to deploy in the next 12 months.
Wow.
So our software in 2 weeks was deployed more than we expected to deploy it in a whole year. And that pace carried on.
Wow.
So for us, we've been supporting COVID patients at home in virtual wards, been supporting more and more long-term conditions patients. And more recently, we're being commissioned, which in NHS terms means purchased, across full health systems to deploy that platform to build pathways for every condition that's in every condition that exists in that locality.
Right.
So
and why do you think, particularly? Obviously, I understand the virtual ward piece, or the virtual delivery of primary care services, because people couldn't go to the GP because the GP surgery wasn't seeing patients, or it was only seeing a very small number of very urgent cases, or however it ultimately sort of shook out. But why do you think for those disease conditions there was suddenly such a switch to saying, oh my goodness, for every single disease, or for a much more expanded list of diseases, we now need digital pathways? Was it the same reason, or was it just sort of rising tide raises all ships, and let's just do everything digitally? Or what do you think?
So if I go back to one of the questions that you asked me earlier, what are the challenges? What are the things that we think we fixed? In this regard, the problem is that there's more sick people than there are hours in the day for clinicians to try and resolve on their own, particularly in the traditional way. So what digital gives, in just about every pathway, to some extent, that gives the ability for us to help more patients through the system at the right time.
And dare I say, at a cost that's sustainable, or not, or is cost less of an issue?
That's a good question. So I think probably at the moment, their cost is less of an issue, not because digital is increasing the cost, but because what you're doing in getting the right patient in at the right time and giving them the right treatment, that itself reduces the overall cost.
There's like a cost saving because of the efficiency of the delivery just inherently in it.
In lots of different ways. So that might, if you look at diabetes, for example, diabetes is relatively inexpensive to manage up until someone starts to get side effects from the diabetes condition itself.
Yeah.
And that then makes it one of the most expensive conditions to manage in the health service. It accounts for about 10% of the 150 billion a year that we spend on.
It's
on
massive.
If we can help support those patients to be better for longer using technology that's relatively inexpensive, then those costs don't come, or if they do, they're pushed further away, and people themselves stay well for longer.
Makes sense.
Yeah, if someone's going into hospital and we can make sure that when they go into hospital, they're the right weight, they're in the right physical state, they're healthy enough to go and have their operation, that means less cancelled operations, because there's a significant percentage of operations that are cancelled because when someone gets there, they're not right to go and have it. So that rehabilitation for the operation means that those spaces aren't missed and the expense isn't lost and wasted in the system.
Right.
There's also a huge amount of time that people spend in hospital where they could be supported differently, which is where that virtual ward comes in, to get people to hospital quicker, but keep them monitored by the same clinical teams, just in their own homes with the right information supporting them.
Makes sense. I mean, makes total sense. So we've got a few minutes on the left on the show. It's good. It's flown by. It's been great to have you on. So before we go, I would just like to, obviously, as an entrepreneur, you know, who's been running his own company for quite a while now, how do you kind of keep, and I know that team spirit and culture is important to you and important to the organization, and so how have you managed to keep that motivation and keep on your mission? What kind of lessons or behaviors or strategies or advice have you received, or do you listen to, or, you know, what can you share with us in the audience?
I think probably that you mentioned it earlier. I'm really lucky. I've got a great team around me. I've always been really open and transparent and vulnerable about the stuff that I'm really rubbish at. And so my job, I've literally got 3 objectives, and 2 of those revolve around bringing in people who do things better than me and that are brilliant. And one of them is around creating an environment for those people to excel in. What's that look like? That brilliant environment essentially means that I spend most of my time being a mischievist, as you mentioned at the start, trying to remove barriers. You know, where there's red tape, chop it. Where we haven't got to do something, just find a way to move it out of the way.
Right.
And make sure that we're all aligned to try and deliver things in the right direction. That we're all incentivized. And if I give one example of that, we have a big target to go and achieve by March 26. And if we achieve that, we're splitting half of the company's profit with all the staff through share.
Wow, that's great. That's fantastic.
And incidentally, one of those targets is to go and deliver Clinitouch, that digital healthcare platform, free to one developing nation.
Wow, that's great.
And that's part of the corporate incentive program.
Well, Chris, we've run out of time, but thank you so much for coming on the show. Chris Barker, CEO of Spirit Health Group. If anyone wants any more information, what's the website?
www.spirit-health.com.
Perfect. Thank you very much for coming on the show, Chris, and thanks to everyone for listening. We'll be back again next week.
Thanks so much, Steve.